मैं बिल्कुल ठीक हूँ।
हेलो सर।
गुड इवनिंग टू यू।
गुड इवनिंग सर, कैसे हैं?
मैं बिल्कुल ठीक।
गुड सर।
Let's launch. हाँ।
Yeah, good evening, sir. Sir, I'll start.
Yes, I suppose so. So today we have a patient of lower urinary tract symptoms. Is that right?
Yeah, sir.
From BL Kapoor.
Yes, sir.
Yeah. You can start with your presentation. Start sharing your slides.
Sir, I have some slides for the later part investigation. The rest I'm just an oral presentation.
Yeah. Okay.
Sir, my patient is a 30-year-old Hindu married male resident of Noida and has a clerical job in a private college in Noida. Presented with chief complaints of poor appetite around 10 days with fever and burning micturition of a week of around 7 days, and then decreased urine output and breathlessness, which was present since 3 to 4 days. So history has been given by the patient and his elder brother, and the history of the patient dates back to around 12 to 13 years back when he started having problems with his urinations. He recalls an episode of urinary retention for which he was catheterized for a day at a local hospital. He passed urine, and after one day later, the catheter was removed also, and patient does not recall any investigations done at that time, any blood or urine investigations or any imaging done at that time. Subsequently, his problem with urination started increasing. He has to strain every time he passes urine. Gradually, the amount of pressure he has to apply started increasing, and sometimes he was not able to pass the urine. Then he used to wait for 2 to 3 hours, and then again repeat the act of urination, and usually he was able to pass urine. There is the history of burning micturition, which was present several times during this period of 10 to 12 years, and patient used to take medications from a local practitioner or a local chemist, and it used to subside, and never consulted a medical hospital or a proper medical never seek proper medical help. And along with that, there was history of hesitancy, even intermittency, and and there is increased frequency of micturition was present at sometimes. There was history of nocturia was also present, and although patient did not give history of any incontinence or nocturnal enuresis, uh, patient gives along with that, patient also has history of progressive weakness of his urinary stream, and there was a dribbling of urine at the end of the micturition. Also, there was no incontinence of the urine as well as the stool, as there is no history of any chronic constipation associated, and no history of any hematuria, passage of stone or gravel or flank pain at any time. There was no history of erectile dysfunction, and now the patient and now the patient presented with history of poor appetite since around 10 days, which was associated with nausea and vomiting. So vomiting were 3 to 4 episodes were there in a day, which was non-projectile and contained the foodstuff. Then patient going on to develop burning micturition since around 1 week with exacerbation of his urinary symptoms. And initially, for 1 to 2 days, 2 days there was no fever, but after that the patient developed fever, which was high grade around 101 degree Fahrenheit. It was a continuous and
101,
associated.
you said.
Yes, sir.
101.
Yeah.
101 is not
102.
high grade. Okay.
101, 102. It was sometimes associated with chills, but there was no rigors. It was a continuous fever, and we used to relieve on medications. And since then for this fever and burning micturition, patient reported to a private hospital, and where patient was started on some oral medications, the nature of which is not known to the patient. and a patient was subjected to some ultrasound scan and was referred to a kidney specialist. And where he undergone certain blood tests, and he was told that he has a kidney failure and his creatinine is very high, and further imaging tests were ordered. In the meanwhile, the uh, patient developed breathlessness, which was initially it was on exertion, but it rapidly progressed to breathlessness at rest, although there was no orthopnea, cough, expectoration, or chest pain. And since last 3 to 4 days, he also noticed decrease in his urine output. And for this increasing breathlessness, patient was brought to our hospital in emergency, and where he underwent one session of hemodialysis after insertion of an right IJHD catheter. Patient did not give any history of swelling of limbs or frothing of urine. There was no history of any rash, joint pains, or any hearing loss, vision abnormalities, no history of any herbal medications or NSAID abuse. And coming to the past history, uh, as far as the birth history is concerned, patient and his brother remembers that he was delivered at home. It was a normal vaginal delivery, but whether it was a preterm or full term, or whether there was any complications in the pregnancy, the brother was not sure of that. And according to the brother, he could not comment on his milestones, but according to him, he was average in studies and has completed his graduation. And other history pertaining to his childhood history regarding any urinary tract infections in childhood or excessive crime during micturition or bedwetting, I was not able to elicit in history from the brother, and he was not sure about that part of the history. And as the personal history is concerned, he's a non-diabetic, non-hypertensive, consumes a vegetarian diet. He is married. 8 years back, he was married and had two children, a 6-year-old girl, and a 3-year-old boy. Both the children are healthy. Family history, no significant family history of any renal disease or any other significant history was present. He had two elder brothers and one younger sister, and all were healthy with no significant ailment. So this was about the history.
Anybody wants to ask any questions? Has there been a history of double voiding for all of these 12 years?
Sir, no, mainly double voiding. He doesn't give history of. Sir, the double voiding means the double stream, sir.
No, double voiding means you go void, come back, and within minutes you want to go and void.
Yeah, sir, not like a double voiding, but he gives history of like during the micturition there was hesitancy, as well as there was like intermittency. He used to stop for a while, and then again during that act only he would used to pass urine. But the proper history of double voiding was not there.
Okay.
Although during the episodes of yes, sir.
The last childbirth you said is 3 years ago.
Yeah, 3 years ago.
Okay. You will be giving us his anthropometric measures, no?
Yeah.
Whether there is any stunting of growth or any such thing?
No, sir. As long as the history is concerned, the proper milestone history could not be elicited from his brother. The brother was only 2 years elder from him, but according to him, he had a normal childhood history with normal milestones and normal education. It was average in studies. Has completed his graduation, and no such problem was according to him, that there is not the detailed history could not be taken, but nothing but significant was there.
Okay. Anybody else wants to ask any question? If not, you can go on to examination.
So on examination, patient was conscious, oriented to time, place, and person. He was thin built. He was lying comfortably on bed with follies and an HD catheter in situ. And he had a weight of 50 kgs with height of 170 centimeters, BMI of 17.3. His blood pressure was 100 by 70 millimeter of mercury, right arm supine position, and pulse was 110 per minute, which was regular, bilaterally symmetrical, was normal in volume, no special character. All peripheral pulses were felt. Respiratory rate was 24 per minute, abdominal thoracic. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema, which was noted. JVP was not raised. There was no skin abnormality which could be found, and there was there was no any abnormal facies or abnormal uh, signs were noted. Fundus was also normal. And coming to the systemic examination, I would like to examine the abdomen first. On inspection, he had a scaphoid abdomen with umbilicus being central inverted. All quadrants were moving well with respirations. There was no scars, sinuses, any swelling or any dilated veins over the abdomen. Hernial sites were free. And inspection of the external genitalia was done, and no abnormality was detected. There was no phimosis or no ulceration, nothing. The findings of inspections were confirmed on palpation. There was no local rise of temperature, uh, although the bladder was palpable as a firm tender mass around 3 centimeter below the umbilicus, and there was also the tenderness was also noted on the in the right lumbar region also. Uh, uh, the, the examination of external genitalia was done, and both the testes were palpable, and there was no abnormality was detected. First auscultation was normal. There was normal bowel sounds were heard, and no shifting dullness was present. And patient and the consent was asked for the per rectal examination, but patient did not give consent for the same. And coming to the CNS examination, he had got a normal higher motor functions, cranial nerves being intact. There was no sensory or motor deficit which was present. All the DTRs were preserved, and even these superficial ankle reflexes, the bilateral plantar was flexor, the abdominal reflexes were present. I did a cremasteric reflex which was intact, and although patient did not give the consent for the bulbocavernous reflex, and even in the examination of other system like examination of the respiratory system and even in the and cardiovascular system did not reveal any abnormality.
No, so tell me one small detail. You said he had a Foley's in C2,
Yes, sir.
and
Sir,
yet
yes,
he had
yeah,
a 3 centimeter palpable bladder.
yeah, sir, a palpable mass, probably a bladder was palpable even after it was decompressed with the Foley's catheter.
And he had tenderness on the right flank.
Yes, sir, right lumbar also.
Okay. So, what is the provisional diagnosis?
So here I had a 30-year-old male with a long-standing history of lower urinary tract symptoms with recurrent episodes of urinary tract infection, and now presented with a fresh episode of urinary infection, probably a pyelonephritis, and along with the uremic symptoms, and has been dialyzed, has been given one session of dialysis. So my syndromic diagnosis will be in a case of an acute kidney injury on a chronic kidney disease, and probably the cause of acute kidney injury here is the first I'll keep it as probably urosepsis or secondary to pyelonephritis, and and, uh, and the cause of chronic disease, chronic kidney disease, I'll keep it as an obstructive uropathy. And
Obstructive uropathy. So, what are the possibilities in the spectrum of obstructive uropathy?
so in this patient, since he has presented with in history, he has presented with signs of the signs of outlet obstruction, like he has presented with he has to like straining. He has to strain every time when he passes urine. Then he also gives a history of hesitancy and intermittency also, and along with that, during the irritative symptoms like frequency and nocturia is also there. So in this patient, I like to keep a obstructive uropathy secondary to, and also in examination, uh, there's a bladder which is palpable, probably a bladder outlet obstruction. I would like to keep as the first uh, probability in a obstructive uropathy, and the etiology behind bladder outlet obstruction, and probably would first would be an probably a urethral stricture. Uh, Second would be an probably an posterior urethral valve, secondary to posterior urethral valve, and third would be a urogenic bladder.
You found no evidence of any other neurologic abnormality.
Yes,
Is
sir.
that right?
Yeah, that's why I'm keeping it as the probably a third possibility. On examination, also, I've there was no there was no history of in history also there was no any history of trauma to the spine or trauma or focal deficit or history suggestive of the neurogenic involvement. And in examination also, I haven't found any spinal abnormalities and anything in neurological examination. Probably
Uh,
the first would be a urethral stricture, or with this type of bladder and this type of history, and with outlet obstruction would be a posterior urethral valve.
and what made you say that he has pyelonephritis?
So that will be a fever, high grade fever with
Can
burning.
cystitis not give you high grade fever?
Yeah,
With a 3
by the
centimeter
history,
firm bladder, no.
I would, I, yeah, with history, I'll keep it as a probably UTI, probably a cystitis, but with the right lumbar tenderness, I'll have kept as a pyelonephritis.
Unilateral.
Yes, the tenderness was unilateral.
Okay. Hmm. So let us see the investigation panel.
Uh, for on investigation, sir, on first the urine examination, showed a protein of 2 plus with the leukocytes which was more than 50 per high power field, with presence of RBCs which are full field RBCs, and also there were no cast crystals which were noted. On blood investigation, his hemoglobin was 10.7 with TLC
No,
of
bacteria seen, leukocyte esterase seen, nitrites
no,
present.
no, they were negative. The leukocyte esterase as well as the nitrite was negative. Although there was a trace of ketone was there, but uh, this was the leukocyte esterase and nitrites were negative. Uh,
Okay.
the
For
CBC
60 cells to give no leukocyte esterase would be odd, but anyway. Okay.
and sir, his CBC revealed an hemoglobin of 10.7 with a TLC of 13,000 with 94% neutrophils and a platelet count of 1.6 lakhs. And the ABG did show a metabolic acidosis with pH of 7.1 and a bicarb of 9.8. His blood urea was 224 with creatinine of 9.8 and with calcium of 6.7 with phosphorus of 5.8, and the liver function tests were normal, and those CRP and procal was raised. And CRP was around 125, procal was 3.6, and then on ultrasound,
Alkaline phosphatase.
the alkaline was 68. Sir.
Okay. Ultrasound.
Yeah, sir. Ultrasound Ultrasound showed a bilateral gross hydronephrosis with hydroureter with a thick trabeculated urinary bladder with a pre-void urine of 380 and a post-void urine of 160. This was done prior to the coming to our hospital and prior to the when we were given a follow-up catheter insertion. And
Post-void is 160 cc.
yes, sir.
Residual volume is 160 cc.
Yes, 160 cc.
PVR.
Yes. And sir, then he was subject, then further he was subjected to CT as well as he had done RGU MCU, which was done, and this was his RGU and MCU, which was done, and sir, RGU revealed a penile and a bulb. It showed the interior part of the urethra, which was anterior urethra, which was normal, and MCU showed a bladder which was significantly trabeculated bladder with multiple diverticular formations, and this is an irregular shaped bladder and, with significant narrowing at the posterior urethra.
Yeah. Quite evident.
And then a CT was also done. CT revealed the bilateral gross hydronephrosis with hydroureters with cortical thinning in bilateral kidneys and with a thick bladder wall with trabeculated with variable size diverticulums with some amount of bilateral perinephric fat standing was also seen. Okay. CT it was done.
Yes, it is pretty evident. Bilateral hydronephrosis, hydroureteronephrosis. Okay.
Yes.
Right. No contrast was given.
No, sir, no contrast. This was a plain CT which was done.
Okay. Okay. So, so now with the imaging, what do you think is the provisional?
Sir, now the provisional, like in with a thick trabeculated this kind of bladder and with bilateral hydroureteronephrosis, probably secondary to that's probably a consequence of a secondary VUR. Uh, in diagnosis would be in a probably an first would be a posterior urethral valve, and although the second would be in a urethral stricture, and a third will be a neurogenic bladder.
He already has a 2+ proteinuria. Is that right?
Yeah, his urine did show 2+ proteinuria.
We've done a PCR on him.
No, sir.
Okay.
But there was no history of any swelling of limbs, any hematuria,
No,
any.
that is not necessary. No? I mean, yeah, because over a period of time with back pressure changes, if protein appear in urine,
Yes.
then already the nephrons have begun to get affected, isn't it?
Yes. Yes.
Did we plan any other imaging, radioisotope imaging for renal scarring?
But, the patient is already having the renal on his dialysis on already on dialysis. Not this renal imaging. Probably a urodynamic study would have been planned, which is yet to take place. But is already the creatinine is around is 9 or 10. So probably a radionucleotide study will not be an option.
No, so after the dialysis, what difference does it make?
So,
Because
mhm.
one of the most eminent renal failures to treat with dialysis is obstructive uropathy. It can rapidly bring the creatinine down. It can normalize the acidosis, and thereafter you can plan your investigative workup. So, after he's received only one dialysis with you so far?
No, sir. One dialysis was given, and then he did get stabilized. And due to financial reasons, then he was discharged, and he was on IV antibiotics at home also, and then has received two
Oh, he's already been discharged.
discharge on request, and to be followed up. Then after he was followed up once of he has undergone a second dialysis also, second and third dialysis also, and now being worked up further on OPD basis.
No, because why I ask is he's still hydronephrotic. If we decompress his kidneys, some variable amount of function may get returned in obstructive uropathy.
Yes,
So
sir.
that is why I asked the question. He's been discharged a little prematurely.
Yeah,
We need to see whether the kidneys are already getting polar scars. We need to see, uh, whether we can make a difference to the renal function to get him to a non-dialysis dependency, and then work him up. Not that if it is a posterior urethral valve for which elaborate cystoscopic examination would be necessary, it is a little late. He's 30 years of age. Secondly, his BMI is rather low,
yes.
isn't it?
In,
At 17, it is rather low. For a 170 centimeter individual, he is only 50 kilos.
yeah, he's thin built.
Yeah, so we needed to see whether the urinary tract infection itself, with which he's been suffering over the last 12 years, whether it is some kind of a chronic infection or whether it is episodic, intermittent, acute infections. We have not worked that also up. You know, though the bladder is not exactly thimble, it is largish bladder and highly trabeculated. So there is no doubt that lower urinary tract has some obstruction. And in order to overcome that obstruction, he has been straining. So there is a possibility very strong uh, of posterior urethral valves, but we still need to prove that contention. We need to do a cystoscopy. We need to also evaluate the kidneys for polar scars. We need to see if there are skeletal abnormalities already in place. You told me alkaline phosphatase is normal,
Yeah,
but calcium is rather low, 6.7, you said, isn't it?
yes.
Hmm. Hmm. So what do you offer him? I mean, on the face of it, it is a lower urinary tract obstruction, or which has resulted in this neglected over 12 long years. He is not paid attention to this. At 30 years of age, you do not expect prosthetic issues, isn't it?
Yes, sir.
So also the very clean neurologic examination, to my mind, with no incontinence of stools, incontinence of urine, a pure neurogenic bladder also is less of a possibility, because then you often by this time get atonic large bladders, by this time, because 12 years is a very long period of time. So it does not appear to be a classical neurogenic bladder. Mm.
Yes, sir.
So a stricture urethra is also mm,
So,
can only be surmised if somebody did a proper cystoscopic examination and the urodynamics. तो वो भी नहीं हुए हैं. So we have an incomplete diagnosis actually, other than the fact that a neglected obstructive uropathy has led to an acute on a chronic CKD. They can preserve a reasonable amount of hemoglobin and they can be edema free. They can go into acidosis early. They may not have hypertension. All that is fine because salt and water keeps getting excreted over a period of time, so they don't get hypertension. But fine. But he has damaged his nephrons. So that needs to be worked up instead of just calling him a CKD and then treating him as such. Even if we gave him a few years or a few months of dialysis, it will be worthwhile. So we need to do some more.
Yeah.
How is the latest urine examination? Has he become afebrile?
yes, sir. He had become afebrile, and though
We didn't get urine cultures, this
it
thing
was
report from you.
yeah, it did come, but it was sterile pyuria, and it was probably outside. Also, he was started on antibiotics and uh,
A sterile pyuria. Mhm. Okay. Have we attempted to work him up for even genitourinary tuberculosis?
uh, sub- uh,
Huh? We should. It should not be ignored because it could be a chronic UTI of that kind. Like I said, by now, of course, you would have 12 years of history. You would have got some changes which are more elaborate in the kidneys, but progress can be variable. And then he is underweight.
yes,
So that workup should also be done for chronic UTI, sterile pyuria. So we should do ISMAN2, we should do urine for AFP, those things. When is cystoscopy planned? Or are we planning any?
yes, sir. We are planning for the.
Has the urologist seen him?
Yes, sir. Urologist has planned his UDS, the urodynamic study, and probably after that a cystoscopy and probably uh, uh, he might merit a bilateral bilateral stenting and decompressing and then following it up with the whether there is any residual renal function left or not.
Dr. Anurag Gupta?
Yeah. I'm
Please.
sorry. Yeah. Uh, just hold on. Listen me.
Yes, sir.
We can hear you.
Yeah, 12 to 13 years ago, he was having urinary retention, right?
Yes, sir. He had urinary retention.
Prior to that, he's not having any symptoms.
Sir, it was around that time only he started having difficulty with urination, which then he had an episode of urinary retention, and for which he was catheterized.
At the age of 18 years, he's first time having the symptoms,
Yes, sir. So,
right?
yeah.
And the issue is, if we are thinking about posterior urethral valve as the first possibility, right?
Yes, sir.
And somebody, it comes under the category of congenital abnormality, right?
Yes, sir. Okay.
Somebody is having posterior urethral valve, how he can present at the age of 18 years with first symptoms? Number one. And then you told after urinary retention, there was, after 1 day, they have removed the catheter, and any evaluation of renal function test or anything was done at that time?
Sir, no, I specifically mentioned that he does not recall any blood urine or imaging which was done at that time. And, sorry, you are muted again.
Repeated urinary tract symptoms, and this time he landed up you with the advanced renal failure, right?
Yes, sir.
Okay. Now, with this history, what is your diagnosis?
Sir, with this history,
Actually, prior to this episode, there was no renal function test reports you are having with you, right?
no, sir. Yes, sir.
And no history suggestive of chronic kidney disease in your history with this episode. Nothing like any, the loss of appetite is just for 10 days.
Yes, sir.
And there was, in history wise, I am asking you,
Yes,
there was no history of any bony pains,
sir. I think
any
no.
decrease in urine output prior to this episode. No decrease in urine output. Only thing is hesitancy, forcing for the stream, right?
Yes,
only this thing was there in your history.
Sir,
And there was no point to suggest that there was a chronic kidney disease in your history, right?
Yeah. Sir, yes. Rather,
With your history, what is your diagnosis? Just on the basis of history, what is your diagnosis?
sir, still with the history only, I have syndromic diagnosis. I have kept as an acute kidney injury, probably on a chronic kidney disease as first, and probably second would be an acute kidney injury. So because acute kidney injury, because again he has a short history of decreased urine output with all there's a short history of these vomitings and all. Plus
so on the basis of, you can say the first diagnosis is acute kidney injury, right?
There's a prolonged history of recurrent infections plus prolonged history of
recurrent history of prolonged infections and everything, recurrent UTI, but don't have anything suggestive of chronic kidney disease in your history.
No, sir. There was no, as such, there was no symptom. There was no nothing to suggest like.
This time, the history is very short. Poor appetite from last 10 days and fever and burning sensation from last 3 to 4 days, right? This is your presenting complaint.
Yes, sir.
Right? And in their history, there is nothing like patient is having any generalized weakness, any loss of appetite, early morning vomiting, or loss of weight, right? There
Loss
was
of weight is there.
No,
that is there, sir, but basically it was 50 kg and no.
Yeah, 30-year-old, 170 centimeters is definitely a BMI of 17 is low.
But there was nothing in the history, sir.
There's nothing in that history in that sense. He's been having symptoms off and on for 12 years.
Yeah.
That itself is a longish history, you know. He's just gone to a chemist and taken drugs and gone on.
Yeah. So what is your probable things for AKI? It's a AIN, ATIN, and the cause of AKI.
First, because he has presented with history of fever, high grade fever with chills with and with vomitings. So first I would keep it as an sepsis 18 only. Probably there is a component of recurrent vomitings also to lower down. Maybe it has added up to the prerenal injury has added to it with he was having poor intake. He was having recurrent vomitings. And third would be probably we cannot rule out acute interstitial because he was taking certain drugs for this. He's taken antibiotics.
You
And,
can say ATIN, multifactorial infection, drugs, and
yes.
your pre-renal component. So what is your diagnosis for chronic kidney disease?
So for chronic kidney disease with the symptoms of lower urinary tract symptoms, I'll keep as an obstructive uropathy with the bladder outlet
I want to
obstruction.
know the first what could be pathology you want to see, and then I want your the etiology. In any syndromic diagnosis, one is chronic kidney disease, then there is the pathology, then there is the your
Etiology.
etiology.
Yes.
In chronic kidney disease, what we suspect? CGN, CIN.
Sir, and an obstructive etiology, obstructive uropathy, secondary to an outlet obstruction. The etiology.
So chronic interstitial nephritis, na?
Yeah.
Chronic
You give
obstructive also.
Yeah, because you've given us long reasons, no edema, no hypertension,
Yes.
isn't it?
Yeah.
So you expect a chronic tubulointerstitial nephritis of some kind, no?
Yes, sir.
Or do you expect a glomerular disease?
No. There's nothing to suggest the glomerular basis of this.
That's what I'm saying. So you should be able to say that, no? Because a 12-year long history and a chronic tubulointerstitial disease is likely in the chronicity part. Of course, there is an acute element. He's run fever. He's got burning micturition. He's got decline in urine output. So that part is acute, fine. But there is an element of chronic tubulointerstitial nephritis, which they are often lean, non-edematous, normotensive. They, of course, may have anemia out of proportion to the degree of renal failure, but that you did not demonstrate. A 10.7 hemoglobin is what you mentioned, isn't it?
Yes, sir. Yes.
Then he also had flank pain. He had flank pain?
Yes, sir. Yes.
Yeah.
So in this, you are saying obstructive uropathy. Your diagnosis is obstructive uropathy. Now for obstructive uropathy, what is your first, second, three? What is the etiology for obstructive uropathy? 1, 2, 3.
Sir, on the basis of history and examination.
No. I'm just asking on the basis of history only. The first the examiner will go only on the basis of history. Then here comes the examination and then comes the investigation. I'm just asking on the just basis of history. 1, 2, 3.
The first would be probably a urethral stricture. Because he had a history of this catheterization, which was done, or it could be
catheterization was done because of retention.
Yes, sir, yes.
So you're suspecting urethral stricture.
Yeah.
So this urethral stricture is because of what? Iatrogenic, you're saying, or you're saying secondary to some infection, or this is pre-existing.
So probably if not iatrogenic, probably a traumatic or an secondary to an infection.
Prior to catheterization, it was totally okay. How can it be traumatic and anything?
Yeah, he did not give history of any major trauma, but yeah, he had certain minor injuries and falls. He did have history of probably an secondary to infection or.
There was no history prior to your age of 18 years. There was no history of any infection, right? There was no fever, nothing. As per your history, all of the things they were happened all of a sudden, right? As per your history, this child having no bedwetting, right? no poor streaming prior to that in your
No, not before.
yeah. So how will you
Actually, the
how
history of bedwetting and the UTIs in childhood, uh, I've, I've
get
mentioned, but because the history was not cannot be elicited because the mother was not available and his brother was not sure of it. So that history part, the childhood history was not cannot be was not elicited for.
okay? So to let see, it's very to say it's a posterior urethral valve at the age of 18 years and prior to that nothing. It is very strange. Basically, usually the patients start having symptoms at the age of 5, 6 years or 7 years, 8 years. And those patients usually have symptoms of small, they have small statures, poor weight gain and all that. So something at the age of 18 years, if you say everything was normal and all of a sudden thing happened, so there is something lack in your history.
Probably he was compensating before that. He was compensating, and I've mentioned that this has been a progressive. Even in this 12 years, this he has been a progressive course. The training also it has been increasing every.
All the things as see whatsoever the symptoms they have occurred only after the age of 18 years, not prior to that.
Yes.
My question is that if something is happening prior to, if we are suspecting posterior urethral valves, then it's come under the category of Kakut.
Kakut.
Right? It's come under the category of Kakut. So the Kakut is a congenital anomaly, which is present at the time of birth.
Yes.
Right, so something is there. So definitely he's having urethral stricture and all that. So definitely acute on chronic kidney disease. The chronic kidney disease is chronic interstitial nephritis, obstructive uropathy. You can say urethral stricture. Your possibilities, matlab ki the history could not be elicited. There is no iatrogenic, nothing is your post-infectious, and is there. And the second thing, you have told that you are planning for bilateral DJ stunting. So
We haven't planned for. We haven't planned.
Bilateral DJ stunting will helpful. Did you get any obstruction at the level of ureter?
No, sir.
Then how the bilateral DJ stunting will be helpful? Whatsoever is the obstruction, even in your MCU, it's a narrowed urethra, right?
Yes,
Posterior urethra. So I don't think so. Even you do the bilateral DJ stunting, you will be get benefit in this patient.
We have to release the distal obstruction.
To that, I would defer, because if you have evidence of bilateral hydronephroureterosis, relief can bring the load of infection down quickly. It is very, very well documented in urologic texts that bilateral pyelonephritic kidneys, where this guy ran fever and so on, and bilateral hydronephroureterosis. By doing a DJ stenting, you can drain the kidneys better, and you can relieve the renal failure as well as the infection a little more quickly. This is very well documented.
Sir, actually,
It may not relieve the lower urinary tract symptoms.
yeah.
That is a different issue altogether. But back
Actually,
pressure changes have caused problems.
Yeah, it's a problem is at the level of urethra, and the ureter is dilated.
Yeah, at the level of bladder neck, I would say.
Yeah,
Because if you see the CT, it's a very heavily trabeculated, not small bladder,
yeah,
and it is trying all the time to overcome the bladder neck.
yeah.
So, a good cystoscopy followed by a BNO may help, I know, but
Yeah.
prior to that, you need to bring the infection load down, and there bilateral DJ stenting can be of help, because a good drainage established gets rid of a lot of things.
Yeah.
Okay.
So basically, at this creatinine, there is not going to help the DTPA scan. Basically, the DTPA scan with diuretic challenge can give you some answer. We have patients who, when you catheterize the patients, the creatinine get normal. Still, the bilateral hydrourethral nephrosis is persisting. And if there is obstructive component at the level, then definitely the degestrating will helpful. And as Sir said, some infection, there will be a relief of infection.
Actually, a DTPA is not what I was suggesting here at all, but for
Yeah.
prognostication's sake, with such large kidneys, a DMSA to look for polar scars
Yes.
or any other such structural abnormality is in order. See, DTPA is a functional scan. You
Yeah.
don't need it now because the creatinine is already way up. He's received 3 dialysis.
Yes,
But
sir.
a DMSA would be still relevant,
Yeah.
whether they're all as the scarring, how much is the nephron mass already affected. That will tell us whether we should be treating him now as chronic kidney disease going towards ESRD, or whether there is some retrievability, because I made a statement that lower urinary tract obstructions are eminently treatable in nephrology provided a good job is done on them,
Yeah.
and you
Sir.
can at least reduce the patient to a non-dialysis dependent state for a period of time. But those investigations have not yet been done, unfortunately.
Yeah.
Nobody has attempted a cystoscopy, for
Yeah.
instance.
My gut feeling is this patient will recover to the extent that he may be dialysis independent.
Exactly what I'm saying. So nobody, the urologist actually should be delighted to see this patient. First, he should look at the urethra, then he should
Yeah.
look at bladder neck, then he should look at the bladder mucosa. And all of this he can do while there is a degestant in place so that he is infection free, because all this instrumentation will further cause him otherwise issues. And I again say a hemoglobin of 10.7 is a very reasonable hemoglobin. He says alkaline phosphatase is not raised,
Yeah.
skeletal abnormalities have not appeared. So we should be able to help him. We should
Yeah.
be able to help.
Definitely, sir. Urological intervention definitely required. It's good.
As regards posterior urethral valves, now I have a statement to make after 30 years in the field, and that is that true that congenital posterior urethral valves start giving symptoms actually in utero. In utero, there is a reflux,
Yeah,
but the reflux may be variable, right from grade 1, grade 2 to all the way grade 5. Right now, the way he shows bilateral hydronephrouretrosis, see, the reflux can keep increasing over time, and there is an entity called secondary PUV. Okay, and not that fulguration will help any great deal, because by now the kidney damage may have already occurred. That is why the DMSA. That is why to first evaluate the extent of damage to the kidney. How much of them can be restored, and then in case there are, on Verumundaram, if you still find posterior urethral valves, in order to avoid future obstructions, because the bladder, look at it the way it is trabeculated, we may yet want to get rid of it. Or he may require just a simple bladder neck incision, BNI, in order to relieve the outlet. And so that is why the urology becomes important.
Yes, sir. Actually, he has been planned for UDS, and the plan is probably a bladder neck incision surgery. And,
The other fact that I want to again highlight to all the students is that if he has a 3-year-old kid, then he was number one, sexually active and potent till 3 years ago. Okay. So that time you did not have advanced PKD, because one of the first things that you lose is libido and ability to reproduce. So if he has a younger child who's 3 years old, at least 3 years ago he did not have very severe kidney disease. Okay. Which is why I agree with Dr. Anurag Gupta, we may yet be able to help him out. Do other students have any questions to ask? How many of you have measured intermalleolar distance? Why is it done? Dr. Vishwas,
Yes, sir.
have you ever done a complete skeletal examination in a patient of Kakut? Actually, 170 centimeters seems a very, very good height. Otherwise, average Indian height, 170 centimeters. That does make it more than 5 feet 7 inches. But otherwise, you must have a proper schema in your mind to look at skeletal examination in patients where you suspect Kakut. How do you measure the wrists? How do you measure intermalleolar distance? How do you look at the intercostal spaces? How do you look at the sternum? All of that, because they are important. They are important. And similarly, you should also have your enzymes on your on the top of your mind. Alkaline phosphatase, calcium phosphorus you've done, but you've not done PTH.
PTH was
You've not done
320.
you didn't mention IPTH, did you?
Sir, the PTH was done was around 350.
Huh?
350 was the PTH.
350.
Yeah.
350 is high but not very high. 350 would suggest a CKD, but it does not affect, it does not suggest a very severe hyperparathyroidism. Okay. What are you doing about his serum calcium?
So, right now, sir, he is on regular dialysis. So serum calcium, you're saying?
Yeah, his
So, yeah.
calcium is rather low.
Yeah, so he's given calcium supplements.
Yeah, such patients, he does not have much of a phosphate load as of now. 4.7 is what you said was this phosphate.
Yes, 5 points.
5 points. Yeah, so he can be given calcium-based phosphate binders, and he may require, because of advanced renal failure, he may also require vitamin D supplementation to bring the calcium up. Of course, once the calcium exceeds 10.5, then you can go on sevelamer based phosphate binding, but till then you can use calcium based salt, calcium acetate or something. Okay. So I suppose the investigation is far from complete, and you will have to involve your urologist more extensively and get to the diagnosis quickly if you wish to help the individual. Okay. Any other?
Although the presentation was good, sir. The way he presented it was good. So
Yeah. But I once again insist that only age should not dismiss the possibility of posterior urethral valve because of their location.
तीसरे फ्लोर पे होना चाहिए.
yeah,
मैं जानता नहीं. सेकंड फ्लोर पे.
Yeah.
अरे मैं जानता ही नहीं हूँ।
Okay, so we conclude here. I mean, we have finished with an hour exactly.
Yeah, sir.
And I would trust Dr. Vishwas to, during the next meeting, to give us some follow-up, what is further happening to this patient. Because that curiosity otherwise is never satisfied.
Yes.
Where did we reach with this patient? Look at the size of the kidneys on your screen. I mean, so this needs to be done up. Okay.
Yes.
Yeah. Thank you.
Thank you.
Thank you, Dr. Anurag. Thank you, Dr. Vishwas.
Yes, sir. Thank you. Thank you.
Yeah, please see that we get a little more in history and examination in patients of low urinary tract symptoms, because they are the ones who can give very interesting findings clinically. And like I said, do not ignore chronic infections. So it is still worthwhile to investigate for chronic urinary tract infections where they give sterile pyuria. Okay, thank you.